Yeah,
Maria,
once
you
it
could-
goes on the stream, it's recorded by YouTube and Facebook. Or YouTube.
Understood. Maria, you can start with the medical standards roll call because that does not need to be recorded. You can't do the REMAC one until we're recording, but we're live now anyway, so it's all good. Go ahead.
Okay.
Recording.
So this is the February 9th, 2021 Medical Standards Committee meeting. Please answer when I call your name. Paul Barbara,
Here.
Jonathan Berkowitz,
Here.
Cindy Basilios, Joseph Bove, Neil Semilovic, Wallace Carter, Robert Krupe.
Here.
That was Robert Krupe?
Yep.
Thanks. Jeffrey Douglin.
Lauren Castillo here for Douglin.
Hi, Dr. Cristurco.
How are you?
Reed Caldwell,
Here.
David Lobel.
In attendance.
Hello. David Eng. I thought I saw David. No?
Yep, I'm here. Sorry. Hi.
Okay. Is Matt Friedman here too? Okay. Jeff Rabrich.
Here.
Thank you. Michael Redlener. Dr. Schenker.
I'm here.
Anthony Shalish.
Here.
Rafael Torres. Jason Zimmerman.
I'm here. Jason's here.
Thank you. Nick Alexandru.
Here, Henry.
Thank you. Glenn Asada.
Here.
Hi, Glenn. David Benelli.
Present.
Thank you. Dario Gonzalez.
Here.
Thank you. Doug Isaacs.
Here.
Thank you. Bradley Kaufman.
Here.
Thanks, Brad. Anne Marie Grigenti. Okay, so she's not here. Is Barbara Aziz here? Okay. Kevin Ward.
Kevin couldn't make it tonight.
Okay. Grace Casciola.
Here.
Hi, Grace.
Hi.
Madeline Fong. Sean Graves.
Sean Graves, present.
Hi, Sean. Robert Ackerman. Michael Vatch. Morty Lack said he wouldn't be able to attend. Arthur Cooper.
Here.
Hi, Art. Robert Goldstein. Yadidja Langsam.
Present.
Lewis Marshall.
Present.
Kevin Munjal.
Hi, present.
Thank you. Jessica Van Voorhees. Okay, and that's our attendance, and we have a quorum. 1, 2.
Okay, Marie, so let's do a roll call now for REMAC. This way we can do business as REMAC as well, and then we'll begin with the medical standard portion that David will run.
Okay.
I'm sorry, everybody, that we have to do this twice, but unfortunately, statutorily, I guess. we need to.
Okay, Robert Winchell.
Here.
Thank you. Joseph Schenker.
I'm here.
Michael Vatch or Robert Ackerman. Nick Alexandru,
I'm here.
Eric Cohen, Kevin Munjal, hey, Kevin, you said you were here before. Okay, I'll come back. Sorry about the dog. Cindy Basilios. Cindy Basilios. Okay, I'll have to come back. Grace Cacciola.
Here.
Thank you. Glenn Aceda.
Here.
Dario Gonzalez.
Here.
Bradley Kaufman.
Here.
Doug Isaacs.
Here.
Nathan Reisman.
I'm here.
Kevin Ward. Not here. Anne-Marie Grigenti. Samia McEachin or Allison Burke.
I'm here.
Thank you. Jeffrey Rabrich.
Here.
Reed Caldwell.
Here.
Jonathan Berkowitz.
Here.
Lewis Marshall.
Still here.
Okay. Michael Redlener. Laura Ivacoli.
Sorry, Marie, it's Michael Redlener. I couldn't take myself off mute for a second. Sorry.
Okay.
I'm here.
Okay, good to see you. Laura Ivacoli.
Hi, yes, here.
Hi. Stuart Kessler. Matthew Fink. Wallace Carter. Yeah. Okay. Dominic Battinelli. Efren Rendon. Peter Wire.
Here.
Paul Barbara.
Here.
David Benelli.
Present.
Thank you. Celia Quinn. Timothy Stiles. Mark Cantor.
Here.
Thank you. Joseph Bove.
Present.
Thank you. Sean Graves.
Present.
Matthew Harris. Matthew Harris.
He said he would be here and I sent him the link, so maybe he'll join a bit later.
Okay. Robert Krupe.
Here.
Jessica Van Voorhees. Arthur Cooper.
Here.
Yadidja Langsam.
Present.
Anthony Shalish.
Here.
Okay, I'm just going to go back to Kevin Munjal.
Here.
Thank you. Cindy Basilios. Okay, do a quick count. 1, 2, 5, 6, 7, 8, 9, 10. Okay, we have a quorum. Thank you.
Okay, very good. Joe, so we'll start with the medical standards, I guess.
Yeah, we'll start with medical standards, and any correspondence that needs to be read in will be read in only once and not twice, so it'll make life a lot easier.
Perfect. So let's start. I know that Marie, good evening, everyone. Thank you for joining. We'll start with the Medical Standards Committee with the agenda that, Matt Harris just joined, I guess. He just put a message up in the text. Thank you everyone in the chat. Thank you everyone for joining this evening's Medical Standards and REMAC. Marie has sent out the agendas for both committees and all the corresponding documents. And I think we will start. Marie, everything good?
Yeah, no, I just got a very strange thing that tried to come into the room. So I'm just like not letting that person in.
Okay. I will start with with a motion to approve the agenda of medical standards that was sent out to everyone. I'll take a motion and a second.
Motion.
Second, Sean Graves.
Second.
Thank you so much. If there's, I think that just in favor of time, for the benefit of time, we'll just ask that if anyone is against it, they should let me know. Let us know now. Otherwise, I'll take it that everyone else is approving. Is there anyone who is against or opposed, opposed, or abstaining the minutes? Yes, Art.
Yeah, I don't know if we actually need a motion to approve the agenda. That's normally the prerogative of the chair to set it.
Not the agenda, the minutes.
Okay.
I apologize. So motion to approve the minutes from last meeting. If there's anyone who opposed or abstains the minutes, can you please let me know now? Okay, otherwise I'm gonna take that everyone is approving the minutes from last meeting, and we'll move forward. Marie, let's read the correspondence report, and we'll do that for both committees together.
Okay, you want me to read it? Because I sent it to you and Dr. Schenker.
I have it.
Okay, Dr. Schenker will read it.
Awesome.
So there's a correspondence from the New York State Department of Health, certification surrendered effective 1/17/2021. Firuz Baratov, 467-735 from Staten Island, New York. A $25,000 civil penalty was assessed to Citywide Mobile Response. 12,500 suspended pending completion of a 2-year improved performance effective 1/22/2021. And the ambulance committee is working with Citywide to provide technical assistance. NYU, Flatlands, and Wyckoff all submitted protocol update completion affirmations. And that is it. The protocols we'll discuss under protocol, and the bylaws were sent out as a second review to everyone. So those are the correspondence.
Very good. Any discussion about this? Okay, let's move on then. I believe that we have a presentation, and in the interest of
hold that for a little bit. I want to go through the business first, and then we'll do that at around 5:45.
Okay. Very good. So let's move on to the subcommittee reports. We'll do it in the order of CNC, and then we'll do protocol, and then we'll do the interfacility protocol committee. So why don't we start, Paul? Dr. Barber.
So CNC updates, based on the amount of lift to get the test off the ground for the January reset. There's been just kind of a waiting game. So no actual meetings, but ultimately the test preliminarily has the same pass rate with about 80 test takers in the first 5 weeks. And I think it was the same, similar scoring to the prior. So it looks like the test is at, essentially a status quo. The only problem is only one agency has really done any testing. So we'd like to see a little bit more variety in the student type before we assess the test. But the good news is no one is complaining about it. And in the absence of complaints, I would say we have a successful product on the streets of New York. But that's basically it for CNC. We're just in a holding pattern for more testers to see the efficacy of the exam. Any questions?
Oh, that's great.
Side note, with the exec board and whatnot, we worked on a medical control intake form and a medical control exam. Again, if you're giving medical control, just contact me offline and I'll be happy to share with you some of the new processes we're working on. Thank you.
Thank you, Dr. Barber. I'd like to thank you for the tremendous work that you've been doing, both with the test and with the online medical control credentialing. Amazing work. You've brought us to the 21st century, and thank you very much. Any discussion about CNC? Okay, so let's move to the protocol committee. And we must thank Dr. Lai and the protocol committee for the extremely important work that they've been doing on the continuous effort in bringing our protocols up to date. So thank you, and Dr. Lai, the microphone is yours.
All right, thank you, David Benelli. So the protocol committee met on January 15th and January 29th and have gone through the protocols that were submitted to the REMAC for review that Marie had handed out with the rest of the documents for this meeting. How would you like to proceed in terms of reviewing these protocols? Do you want to make me as a presenter, or does somebody want to just put the protocols up and then we can kind of go through them?
Well, Joe, why don't you make her a co-host?
Yes, it's probably best if you're talking about the protocols that you're the presenter, and the way you can move forward and backwards.
Okay, Pam, they made you a co-host.
Okay, perfect. So I will go through the protocols. I'm going to first to talk about the stroke ones first, so you can have my my screen is up, and you can all see the stroke protocol that I have up. Yes.
Maybe you can make it a little bigger, Pam.
Bigger. Okay. Will do. Okay.
Thank you.
All right. So for the stroke protocol, there were not very big changes on here. It was mostly just for language and clarification that was made for this protocol. In some of the things I think that we had included on here, in particular for the paramedic section, it was the orders of that there should not be any sort of delays in transport. However, that if there is time that they should be able to start cardiac monitoring, as well as be able to obtain intravascular access. The other addition that was made that was consistent with the state collaborative ALS protocols was the addition of metoprolol, 5 milligrams IV slow push, as a medical control option. That was added if available. In addition, for the under the key points and considerations, one particular key point was added on here, especially for those pediatric patients who may have show signs or symptoms of an acute stroke, that they should contact telemetry or OMC for transport decisions to a hospital with pediatric critical care capabilities. Otherwise, everything else in this key points and considerations section was just only slightly modified from the original protocols that the current protocols that we have. There was some redundancy in terms of the key points and considerations, including some of the information that is currently included in our respective appendix section that was just removed from the protocols just for a little bit of clarity and lack of redundancy.
Also, one more thing that was added to the key point was no, I think that's it, actually. Any discussion about the stroke protocol? You've all received this in your email message. This has been discussed extensively at the protocol committee meeting.
Yeah, this is Nick Alexander. I just have a comment. I just wanted to clarify something. Is the decision for pediatric patients with symptoms of acute stroke contact telemetry for transport, is that just, I mean, which one supersedes which one? Pediatrics critical care, or if they meet SLAM score, go to an LVO?
Well, I think that we can discuss this offline, but this is essentially an adult protocol. There are rare and far apart instances where there are actually pediatric patients who do have stroke symptoms. For instance, it could be sicklers or other patients. And in those cases, perhaps it is Dr. Harris, who was serving as our pediatric specialist, recommended that we transport them to hospitals that have capabilities of dealing with stroke patients.
That's fine, but if they don't have any additional kind of conditions, the straightforward symptomatology, are we, because the telemetry docs.
I think that we can
go with this.
I think we need to define that, and I think that is beyond the discussion right now.
David,
Yes.
if we're voting on making this the protocol, it can't really be beyond the discussion right now. If we're voting on it now.
It just needs to be clarified, because these are two different types of destinations, and depending on the patient, with whatever conditions they have, is going to make a difference it needs guidance. It needs to be guided by the telemetry doctor.
Well, why don't we ask, Matt is here. Why don't we see what his thoughts were when he was talking about this originally?
Yeah.
Dr. Harris, if you would just want to kind of speak to this bullet.
Yeah,
Matt?
thank you. Yep, I'm here. Sorry, trying to come off mute. Thank you for the opportunity to chat about this. So pediatric strokes, as you all know, are extraordinarily rare. And the treatment for pediatric strokes tends to be conservative. My concern is a couple things. Most LVO centers won't treat a pediatric patient. So by sending them there, if they're 14, they're just going to transfer them to a pediatric center, and that will ultimately delay care, if care is even necessarily warranted. And frankly, even in our sickle cell population, which is probably the highest incidence of pediatric stroke, they don't get an intervention. They get, they'll get an acute neurosurgical intervention or neurologic intervention. They get an exchange transfusion. My bigger concern is that, and this is a topic for perhaps another day, is that the critical PEDS designation in general in the city is extraordinarily vague and includes some of our freestanding emergency departments. So my suggestion is that children with an extraordinarily rare, presentation who may require an intervention that most non-pediatric tertiary children's hospitals, of which we happen to have a number, they're probably unable to handle it. And so to reduce secondary transfer, I think a conversation with the telemetry doc to identify the tertiary children's hospital closest to that patient would be warranted.
So there's two issues with that. Number one is tertiary is not a definition that is in the New York State hospital designations. Critical pediatrics is. I guess and this goes to what Nick is talking about. If we're going to make this a medical control decision, we probably need to have a discussion as to what are these designations. We're not allowed to change the designation on our own. The state slapped us on the wrist about that in the past. So
right, I'd be happy to be, and I'm sure R would be a part of this. But I think that's exactly where this conversation needs to go. Because what will happen is children will be taken to the wrong place. They will be undertreated, and they will delay definitive treatments because we know where they're going to end up. The fact that the state lags behind in defining centers appropriately is something we need to address and advocate for.
Right, and to my point again, it's the telemetry physician is going to have a hard time with this because again, they're not pediatric specialists, and our pediatrics critical care hospitals are not identified specifically with what kind of care they can provide. So it makes it a very hard decision, even for the physician of telemetry to do that.
I agree. It's a very hard decision, but again, in the benefit of patient, perhaps the telemetry physician would call and say, "Hey, I have a kid with a stroke. Are you able to take care of that kid?" But if this is a point of contention, then I suggest that we just delete this sentence and approve the protocol without this sentence, and leave this discussion for a different venue.
All right, Art has his hand up.
Okay.
I think that might be a better decision overall, because I think we could just stick to our guidelines.
Art had his hand up. We skipped him.
Thank you, Joe. I just want to support Matt Harris in his comments. As he said, the great majority of kids with acute strokes are sicklers who need exchange transfusion. And that really has to be done at a pediatric critical care center. Speaking as chair of the state EMSC committee, a lot of work has been done on identifying those hospitals that have state recognized pediatric intensive care units. It would be easy enough to get that list, for those centers that have that capability within New York City. A lot of this has been done also in the context of work through the New York City Pediatric Disaster Coalition in terms of identifying the hospitals with pediatric critical care capabilities. So I'd be happy to work with whoever we need to work with to make sure we get that list, available to the region. But Matt's points are entirely correct, and as he's pointed out, a primary transport to a stroke center is not going to serve these patients well. They really need to go to a pediatric critical care center, which has the resources to take care of kids with acute strokes. Thank you.
Thank you, Dr. Barbara, and then Dr. Weissman.
I think we're muddying the waters here with what the role of our group is right now. I mean, isn't the role of our group to set the medical decision-making in play and not necessarily the operational considerations that come from those decisions? We've had this conversation several other times, several other situations, EpiPens, certain types of medications, et cetera. The goal of our committee is to set the best medical decision-making for the region. And I would remind the committee that there's more than one medical control facility in this region. And if we have issues with operationalizing a decision, that's where quality programs and training programs for those medical control physicians comes into play. And the region should be hosting education not only for the paramedic, but also for medical control physicians, which are an integral part of our decision-making. So I would suggest we don't change the protocol and we put the best medicine on paper and move towards engaging our providers that might not necessarily be a field provider, but they're a telephone provider, to make those decisions that Dr. Cooper and Dr. Harris are speaking of. Thank you.
Thank you, Dr. Barbara. Dr. Weissman.
Yeah, I would just caution people who haven't been here before for a long time is that the REMAC doesn't really have the authority to designate centers in this way. So I do agree that we should have some sort of designation for critical care pediatrics, but I think we need someone else to make that designation because the REMAC, we've been sued before for trying to make designations.
But correct, this is Michael Redlener. I would just say that, thank you, David. I would just say that if we want to make this a part of medical control options, it's not a designation. It doesn't need to be a designation unless I'm misinterpreting previous actions.
No,
you're correct that if it's a physician-directed referral, it doesn't have to be designated. But if we want to put it into the REMAC protocols, we have to make sure that it's everyone could support it, not just the fire department.
Right, but
Dr.
again,
Schenker.
I think what's going on here is we put language into our protocol. Art, I see. I'll call in just 1 second. We put language into our protocol, which is asking OLMC to make a decision that right now, if we were to implement this protocol, OLMC doesn't have the information to know what the right decision is, whether it's Methodist, whether it's Staten Island, whether it's the fire department, whether it's Mount Sinai, any medical control facility doesn't know what to do with this information. So I agree with the sentiment. I think that it's the right thing to do, but I think that, and going along with what you're saying, Paul, I agree with the operation that we're not trying to operationalize this, yet at the same time, what is the appropriate medicine? Where do they go? And what is that center when we tell them to go there? That's what I think we need a little bit more information. You're right. If it's a physician-directed decision, we're not defining hospitals. But what we've done in the past for this is we've gotten hospitals to agree that they would do A, B, and C to be included on a referral list. So if we're saying that, the major pediatric centers will do A, B, and C, and provide quality assurance back to the region, then we'd have something to tell the online medical control physician to send the patient to that location. And I think that that's the challenge here, is that this language is telling online medical control to do something that we don't know what to do yet. That's all I wanted to say. But Art, and then I think Matt has his hand.
1 second. So Art and Dr. Aseda also has something. He can't raise his hand. And I think that Nathan lowered his hand. So let's start with Art.
Yeah, again, to reiterate what I said a few moments ago, in a different way, back a few years ago, when the state, in the same meeting of the state committee that writes the regulations for hospitals, in the same meeting where they approved the sepsis guidelines, they also approved specific standards for pediatric intensive care units in New York State. That was the list I was referring to. That information exists and can be easily provided to online medical control, so they know where the hospitals are that have state designated PICUs. And that will answer a question that was asked earlier, about our right to designate anything. We don't need to designate anything. All we need to do is tell people who the state has already designated as a pediatric critical care unit. And as I said, I'll be happy to facilitate getting that list to the region. Thank you.
Okay, next, Dr. Aseda.
Yes, thank you. I'm sorry, I can't get on Zoom, so I can't raise my hand. I just want to first correct some of the things that were said. We actually have 2 freestanding EDs in our system, Westchester Square and NYU Cobble Hill. Neither accept any critical care level. That's an agreement they cannot. The other hospital that is technically a 1-bed hospital ED, Northwell Greenwich Village, is technically by definition not freestanding because they are a 1-bed hospital. So they are able to take a little more critical care level patients. Okay, that being said, I'm curious as to how many actual pediatric stroke patients are we talking about? If it's 1 or 2 facilities that can do this, it's very difficult for us to bypass to get to those facilities. Just as we only had 2 pediatric trauma centers in the past, now we're at a level where we have more, but if they're too few, and also how would we identify these pediatric stroke patients? I know you're talking about critical care as well, but pediatric stroke, sometimes we're not very good at identifying our regular strokes and LVOs. So I think that would be another layer of difficulty. So I think it definitely warrants more discussion than passing as a protocol currently.
Thank you. Dr. Kostoko, and I think that Dr. Alexandru had his hand up as well. So Lauren, go ahead.
Thank you. Yeah, I had a comment about something under the key points. I don't know if you want me to wait until this discussion about the pediatric transport is done.
Let's
Okay.
hold off just 1 second with that. Dr. Alexandru, do you have anything further?
Yeah, I mean, it's just sounding, I think we all agree that if we have the centers and we know how to identify these patients, it would be okay to send them to the proper destinations. But in this particular case, when we still have so much up in the air, it's sounding from the pediatricians that the pediatrics critical care hospitals may be a better place to send these patients. Now, maybe until the time we can identify all these other facilities, maybe that would be a good option to put in the key point that pediatrics should probably go to pediatrics critical care if the pediatricians agree at this point.
Okay, Dr. Berkowitz.
Yeah, I mean, I guess my question is, do any of the specialty pediatrics hospitals, do they have existing pediatric stroke protocols that they're using when a pediatric stroke comes into them? Because I know I've been part of attempts to create that at other hospitals and found it to be really hard. And part of this, from a system of care perspective, is thinking of, if we're going to divert patients to a hospital and they don't have a defined protocol for managing those patients, that's just an issue.
Okay, in the interest of time, I think that okay, Dr. Caldwell, and I think that then I think we need to move on. Go ahead, Reed.
Hi, I was just going to say something similar to Dr. Berkowitz. We've had a couple patients, PEDS patients, that have gone to NYU Brooklyn, a comprehensive stroke center for stroke care. And in no uncertain terms, I think JCO, as a comprehensive stroke center, said that we will take all comers for the initial evaluation and TPA when appropriate with no contraindication. So I think we can look further into that as well. Similar to like what Jonathan's saying, even if it's not a pediatric center, they should be able to handle the initial phases of care and stabilization.
Hey, David.
Excellent. Thank you. Yes, Matt.
Just one final statement. Obviously, I agree with it. There's a lot left to be tersed out. To answer John's question, there are very few broadly accepted pediatric protocols for stroke because the cause of stroke in children is so broadly different than cause of strokes in adults. We tend not to have hemorrhagic strokes, and frankly, ischemic strokes are extraordinarily rare, even in sickle cell, and it's a different pathology altogether. That actually is the reason they shouldn't go to an adult center where, yes, they can do a profound neurologic evaluation, but they're not going to have the end therapy that they're going to get at a pediatric center. So I think that the stepwise approach that Glenn and Art and others have alluded to is the right one. Let's identify the centers that might take some legwork, which I think all of us are willing to do. But delaying them to get to a center that can do the definitive care just because someone can perform a neuro exam on them, I think would be the wrong thing for children. I will tell you that wearing my hat as the head of the PEDS transfer program at Cohen's, that the average, acutely ill child isn't transferred for 2 hours. I mean, so we're really talking a very significant issue. But I agree with what Glenn and Art said, that we have to terse this out, identify the centers, like Art said, and then we can reapproach the committee. And I just want to thank everyone for their consideration. I know it's a rare event, but thank you for the consideration.
Thank you, Dr. Haas. Reed, do you have?
Is there enough? I'm sorry, David. Go ahead.
Reed, do you have something else to say, or is this an old hand?
Old hand.
All right,
okay, guys. I want to cut up this. I want to end this discussion, Joe, and I think. I agree. Go ahead. Yeah.
No, I was going to say, is there enough changes to this protocol without this that we need to vote on the protocol, or is the whole protocol going back? What are we doing?
No, I do not think the whole protocol has to go back. I think we
I think we can remove this pediatric language and continue if there are significant other changes that we need to approve. So, Pam, what do you think?
Yeah, I agree. So I have made a note that I will remove this line in the final protocols that I submit to you and Marie. So.
Awesome.
Well, don't we need a motion to change? And,
I think it would be useful to actually have the crews consider contacting online medical control to have a conversation about what the most appropriate pediatric destination for a child with a stroke is. So I'm not sure that I think it should just be stricken from this protocol altogether. We've just had a very extensive conversation about the ins and outs of caring for a critically ill child here. And I think an online medical control physician without a list of pediatric stroke centers can say, yes, that hospital is probably a good choice because it has critical care for children, or they have extreme experience with children, and no, that hospital doesn't have resources adequate for taking care of a critically ill child. Thank you.
Thank you, Dr. Lobel. And Dr. Kaufman raised a valid point. If we're going according to the voting rules, is there a motion to remove this? This was brought a second of motion from the protocol committee to medical standards for approval. Is there a motion to remove that sentence? And if there is, then we have to vote on that. If not, we vote on the whole protocol as it is.
Yeah, I make a motion to remove that from the key points.
Okay, is there a second?
I second the motion.
Very good. So I guess we have to hold a vote. And I think, is the voting option available here for medical standards, or we're just going to do a roll call, Marie?
Only the host would have control of voting if it's turned on for the REMAC Zoom.
What we did in the past was a chat vote for medical standards and a roll call vote for REMAC.
Correct. So if we want to do medical standards, well, we can just, in the chat, you can say yay or nay or yes or no or.
Okay, so we are voting. So there's a motion on the table to remove the sentence that for pediatric patients with symptoms of acute stroke, contact online medical control. for a decision to transfer to a hospital with critical care capabilities. So why don't you please vote in the chat and make sure that you're voting for everyone. If you approve the motion to remove the sentence or oppose. Is someone counting? I am not counting.
I am.
Good.
I'm sorry, we're moving to remove which sentence because I need to write this motion up.
That talks in the key points, the section that talks that for pediatric patients with symptoms of acute stroke, contact online medical control. Thank you.
So that's this fourth bullet.
Okay, did everyone vote? Because I didn't cast my vote yet. I'm waiting for everyone. Is everyone else voting? Okay, I'm going to add my vote as well. Joe, did you count it?
I'm working on it.
Thank you.
Lou Marshall, I vote yes. I'm driving, so I can't chat. Sorry.
We are thrilled for your safety.
I mean, Robert Kruppe voted twice. That's no fun.
Cheating.
Oh, I can vote. I can vote twice too. Anyone on medical standards who has not voted yet, please vote now. This is your last chance.
Are you checking to make sure that only people on medical standards are the ones who voted and not other people who shouldn't be voting? If not, then your voting is bogus voting.
It's
okay,
actually
the only way. I'm sorry.
It's actually 50-50 right now. No joke. 20 people voted, 10 voted in favor, and 10 voted against.
Okay, why don't we do a roll call, Joe? I mean, just to make sure. So, I mean, Yadida is raising valid concerns. Can we please do a roll call, Marie?
Sure. Okay, hold on. Okay, just bear with me because I have to pull up a sheet.
This is medical standards, not REMAC.
Yeah. Yeah, because I have the REMAC voting sheets. I have to just.
What's going to happen if this passes? We're going to have to do this again.
Oh my God. Okay. Okay, you can vote for approve, oppose, or abstain.
And we're voting. The approve is to remove the sentence. The abstain is to keep the sentence, to keep the protocol as is. And abstain is abstain. Go ahead, Marie.
Okay. Okay. Okay, Paul Barbara.
I oppose removal.
Okay. Cindy Basilios.
Oppose.
Okay. Joseph Bove.
Approve.
Robert Kruppe.
Oppose removal.
Dr. Kosterko.
Oppose.
Okay. Reed Caldwell.
Approve.
Jonathan Berkowitz.
Approve.
David Lobel.
I oppose removing the line.
Okay. Jeff Rabrich.
Oppose.
Michael Redlener.
Oppose removing.
Joseph Schenker?
In favor.
Okay. Anthony Shalish?
Approve.
Jason Zimmerman? Dr. Zimmerman? Okay, Nick Alexandru?
Approve to remove.
Okay, Glennis Seda?
Approve.
David Benelli?
I'm the chair. I'll vote last.
Okay, Dario Gonzalez?
Approve.
Doug Isaacs?
Oppose.
Bradley Kaufman?
Approve.
Okay. Grace Casciola?
Oppose.
Okay. Madeline Fong? Okay. Sean Graves?
I oppose removal.
Arthur Cooper?
Oppose removal.
Okay. Yadidja Langsam?
Oppose removal.
Lewis Marshall?
Approve removal.
Okay. Kevin Munjal? Dr. Munjal?
Sorry, the kids are killing each other in the background. I oppose removal.
You approve removal?
No, oppose.
Okay. Jessica Van Voorhees. Okay, you got to give me a few seconds to count this up, okay? I'm going to...
Did you call the wrong list? Because you didn't call me. And you called some people who weren't physicians.
Yeah, because I'm doing medical standards.
Oh, okay.
So, oppose, approve. Okay, sorry. 1, 2, 1. I can't wait to have in-person meetings again.
We won't know how to act.
We can sit in one room with laptops.
That's right. It's just easier to count. Okay. Almost done. Oh, Dr. Benelli, I never asked your vote. You want to give your
Oppose.
vote?
I
You're
oppose
opposed?
removal.
Okay. Oppose. Almost done. Oppose. 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 Okay, so we have 13 opposed and 10 approve.
Okay, so the motion falls. So and let's move on to further discussions regarding this protocol. I know that Dr. Kostulko had some comments about the key points.
Yes, thank you. So the key point that I'm looking at, I may just be misunderstanding, but it looks like, I believe this is Dr. Lai's screen. The last thing on the screen that says if the patient has a SLAM score of greater than 4. So I don't know, Pam, if you can scroll down just a little bit. The So if the patient has an SLAMs greater than 4, the first exclusion criteria is total time from onset is greater than 5 hours. I don't know why we would be excluding those patients. Shouldn't it be greater than 24 hours? Because you could be a candidate.
That's an excellent question, and that is these are the criteria that we, the exclusion criteria that we have established when we rolled out this this protocol, with the thought not that we're missing the 24-hour patients, but they will be sent to a primary thrombectomy, primary stroke center where they can undergo CT angio and decide whether they have a CT, whether they have an LVO, and can undergo thrombectomy later on. Those are the late window strokes. This protocol was addressed and aimed at identifying the acute early window strokes. This is one of the things that we need to review. We're approaching 2 years for the project, that we need to review and address and see what will be the impact of expanding that to 23 or 24 hours. So that is a valid question that will be addressed in the near future.
So is that something would we address that before approving?
No, this is something that is part of the discussion of this, part of the review of this protocol, of this project, that will review probably other exclusion criteria as well, and that will come in the later as a later iteration of this protocol. For now, we're just going through the protocols and trying to mirror what we have, with certain changes that are minor. This is a change that has to be based on research, on review of data, review of what we collected so far, and then we can make that decision. And it will definitely be brought again to REMAC for a discussion and approval.
But again, it's also the state. This is the language that comes from the state as well. The state has this 5-hour time window right now.
Thank you, Dr. Berkowitz.
Yeah, no, I just wanted to agree with you, David. I think that I think it's a valid question. I think that I think it's important that there's a lot of data we'll need to look at, because the data, I think when this protocol was written, was very much supportive of the idea that the time sensitivity in the early window was much greater than the time sensitivity in the later window, when collaterals are playing a much bigger role in patient outcomes. So I think that's the real question, is how time sensitive is it? And so I think that it'll need more than the justice that we can do it in this meeting.
Thank you very much. Any further discussion regarding this protocol? If not, I would like to proceed with a roll call to approve this protocol. Any further discussion? Okay, thank you very much.
A point of order?
Yes, go ahead.
So are we voting for medical standards to approve, and then it will go to the REMAC, or are we going to do a REMAC vote?
I guess medical standard has to approve, and then REMAC has to approve, unfortunately.
Well, that's one of the reasons we were using the chat. Really, only REMAC has to approve it. If anybody from medical standards wants to make a statement now, but we could have the actual vote only once as a roll call at REMAC.
Perfect. Oh, any further discussion?
Is it possible that we could potentially change this language to take that one exception out and just say contact online medical control? I just feel like we're potentially doing patients a disservice here by transporting them to a non-thrombectomy center. You know, say it's 6 hours out and they're a candidate for clot retrieval, or even 20 hours out, potentially more importantly.
Lauren, I agree with your sentiment. I think that this requires further discussion. This is the protocol that was approved, and this is the protocol that we're implementing now. We will make changes. At some point, there may not be even medical control contact when we actually have state-designated thrombectomy centers. But that's going to be in 22 or 23. I think we just need to give time, allow this process, to run, and give time for us to reach the conclusions and see what is the impact of including late window strokes into this protocol. Okay, any further comments? So Marie, let's move on with the roll call for REMAC to approve this protocol.
Okay, and this is the stroke protocol. Okay.
That is correct.
And it's without removing anything. It's just voting to approve. Okay.
Exactly.
Okay. Okay, please vote in favor, oppose, or abstain. Robert Winchell, and this is a REMAC vote.
In favor.
Okay. Joe, I'll hold you to the end. Nick Alexandru,
Yes, in favor.
Kevin Munjal.
I apologize. Can you clarify what this vote is on?
It's to approve the protocol for stroke as it is written.
With the language still in it about the pediatric critical care?
I believe so, yes.
Approved.
Okay. Cindy Basilios.
Approve.
Dario Gonzalez.
No.
No. Oppose? Okay.
Oppose.
Okay. Glennis Seda.
Oppose.
Bradley Kaufman.
In favor.
Doug Isaacs.
In favor.
Nathan Reisman.
In favor.
Okay. Jeffrey Rabrich.
In favor.
Reed Caldwell.
Oppose.
Lewis Marshall.
In favor.
Michael Redlener.
In favor.
Wallace Carter. Laura Ivacoli. Dr. Ivacoli.
In favor.
Thank you. Peter Wire.
In favor.
Paul Barbara.
In favor.
David Benelli.
In favor.
Celia Quinn or Tim Stiles. Mark Cantor.
In favor.
Joseph Bove. Dr. Bove. Matthew Harris.
Apologies, in favor.
Okay. Robert Krupe.
In favor.
Jessica Van Voorhees. Arthur Cooper.
In favor.
Okay. 1, 2, 3, 4, 7, 8, 9, 10. 18 in favor and 3 opposed. It carries.
Thank you very much. I'm sorry, I was speaking to a muted microphone. Okay, very good, Dr. Lai. Let's, so the motion, the protocol is approved. Let's move on to the next protocol, Dr. Lai.
That is great news. I only have 5 more protocols left to go, so this is
Oh my
great.
gosh.
So the next one is abdominal pain, severe nausea, vomiting for adults and pediatrics. This one, I believe that there was only just a few minor language changes, but otherwise this has remained the same. There was no major changes that were made to this protocol.
The one change that was made is the, the nausea and vomiting, the age for administering Zofran, I believe in the collaborative protocols was 2 years. In conjunction with Dr. Harris, we removed that to 6 months because we all treat in the ER babies that are vomiting. There's no reason to avoid that in the pre-hospital setting. Any discussion regarding this protocol? Okay, very good. In the interest of time, can we, let's just do a roll call to vote to approve this protocol. Marie.
This is medical standards, correct?
No, this is a combined
Doing
committee.
this as a joint meeting, you did just, so we have to have a roll call of the REMAC body, and if anybody from medical standards would like to voice opposition or opinion, they should do that now.
Okay, but then essentially you're skipping that there's no medical standards meeting. You're going straight to a REMAC meeting, which is fine with me, but you essentially, unfortunately, by not going through the procedure of letting medical standards people vote, essentially are saying there's no medical standards meeting and you're going straight to REMAC. I'm just telling you that's the fact.
So we're trying to have the medical standards discussion, allow everybody who participates in medical standards to participate in the discussion, voice concern and opposition. We're just trying to avoid having two separate votes back to back, or having this meeting, one and then the other. That's the whole purpose here. We're trying to make
I understand exactly what you're trying to do, and I think it's a great idea, but it happens to be the result is that you are essentially not having a medical standards meeting without allowing medical standards to vote independently. I don't care, but I'm telling you that for the record, you are essentially obviating medical standards. Those are the rules.
Well, for the record, we are allowing medical standards members to participate in discussion. The vote ultimately is a REMAC discussion. So
without a vote in medical standards, you're not having a medical standards vote.
Understood. There are a couple of people who want to comment. I think Dr. Kosturko is first.
Yeah, just curious, why are we doing a repeat dose of Zofran after 5 minutes?
I don't think that changed, Lauren. I think that was there already.
That was there.
Yeah.
Is that normal? Does anybody do that in medical practice? After 5 minutes, repeat a dose of Zofran? I mean, it's not, a benign medication. I don't know, maybe Matt has some way in here.
Nope, we don't do it.
Can we potentially take out that repeat dose?
So
would you want to make it maybe 10 minutes instead of 5? Would that make you feel more comfortable?
I just don't know where we're getting that from.
Yeah, I don't know if we ever redose this promptly unless they've immediately vomited, right? So I think it's a Q6-hour drug.
Right.
Okay, so are you making a motion to remove the repeat dose?
Yes.
Okay, is there anyone who seconds the motion?
Second.
Very good. Okay, so Sean, I know you want to talk, but I think we have to vote on this motion first.
You have to have a discussion on the motion that is on the table.
Yes.
So the motion on the table is to remove the second dose. You can have a discussion on that. People can discuss that point alone, and then we vote on that.
Okay, is there any discussion regarding this motion to remove the repeat dose?
Who votes, medical standards or REMAC?
This discussion, okay, thank you, Yedidia. This discussion now is for medical standards. Okay, seeing that there's no discussion for, yes, someone wanted to say something, I'm sorry.
I don't want, it is Brad. I would just say I would be in favor of that motion, because I think that seems very fast, and we could put a time frame in, but it's probably not the amount of time that the patient will still be with EMS.
Understood. Does anyone want to suggest 15 minutes, 20 minutes, or 10 minutes, or we just remove it?
I would I'm sorry, it's Jeff. I would remove it. I agree with Brad. The time that you're in the field you're generally not going to repeat it in that time frame.
Understood. Any further discussion regarding this motion? Okay, seeing not, I guess we'll have to do a roll call for medical standards to make sure that only medical standards is voting in favor or against the motion to remove the repeat dose. Marie.
Hold on.
Thank you.
My computer. Okay, so this is a vote on to approve the abdominal pain protocol with the removal of the second Zofran dose?
No, this
No?
is not. This is not. This is a vote based on what Dr. Kosturko suggested to remove the repeat dosing of Zofran from the abdominal pain, vomiting, nausea, vomiting protocol. And this is a medical standard vote.
Okay. Okay.
Okay.
Let me just
So
see.
you're going to vote, you're going to say that you approve the removal of the repeat dosing, or you oppose the removal of the repeat dosing, or abstain.
Okay. Paul Barbara.
Aye, I approve.
Cindy Basilios.
Approve.
Okay. Hold on, I'm just counting as we do this. God damn. Okay. Joseph Bove. Dr. Bove. Okay. Robert Krupe.
Approve.
Lauren Kosturko.
Approve.
Okay. Reed Caldwell.
Approve.
Jonathan Berkowitz.
Approve.
Okay. Okay. David Lobel.
Approve removal of the repeat dosing of Zofran.
Zofran. Thank you. Jeffrey Rabrich.
Approve.
Great. Michael Redlener.
I approve.
Joseph Schenker.
I'll approve, sure.
Okay.
Good idea.
Should have just asked who was opposed. Well, it's a lot faster. Anthony Shalish.
Approve removal.
Okay. Jason Zimmerman. Nick Alexandru.
I approve.
Okay. Glennis Seda.
Approve.
David Benelli.
I'm last, but I approve.
Okay, thank you. Sorry, I'm
I
getting
agree
confused.
with that. It's fine. I agree with Dr. Kosturko.
Okay. Dario Gonzalez.
Approve.
Doug Isaacs. Doug.
Sorry, I'm very sorry. Oppose, actually.
Okay. Bradley Kaufman.
Approve.
Okay. Grace Casciola.
Approve.
Okay. And Sean Graves.
Approve.
Okay. And almost there. Arthur Cooper.
Approve.
Eudigia Langston.
Abstain.
Okay. Lewis Marshall.
Approve.
Okay. Okay, and Kevin Munjal.
Approve.
Okay, so we have 5, 10, 15, 18 approve, 2 opposed, and 1 abstain. The motion carries.
Excellent. Okay, so Sean, you wanted to say something, and then we'll hopefully if there's, we'll move to further discussion as protocol, and if not, we'll try to approve it and move on.
Yeah,
Sean.
just in the interest of time, I pose this question more to the parliamentarian than anything. But if there is not a discussion on a particular protocol, can we have a motion for medical standards to defer the vote to REMAC?
That would be great.
Yeah, maybe we can do what Marie suggested, ask only people who oppose to express their votes.
Yeah, if there's no discussion.
Yeah.
Maybe we can
Okay.
David?
Yes, go ahead. Go ahead.
I have a suggestion. To avoid these long discussions, I know it's, Pamela, it's up to you with a little more work on the subcommittee. But if the protocol committee comes up with something, can't they put it out as a first draft and they got X amount of time, a week, 5 days, whatever, to respond? It comes back, they re-put it together, send out the second draft. They got X amount to respond, and then before the meeting, they send out the final copy. And at that point, everybody should have a chance to talk about it. There should be no big discussion about remove this, change the dose, blah, blah, blah. People should have had opportunity to do that because it's hard to do in this size meeting, every month to go over this painful process. So that's a suggestion, Pamela. I just thought I'd throw it out there. So that would be come out, draft, come back, redo it, come out, draft.
Tony, that's a great point. We have a whole committee for this. We have a protocol committee. We discuss this at protocol committee ad nauseum, and then it comes here and we have the same discussion. We want everybody to be able to participate. But this is
what I'm making is that
I think it's getting silly.
Yeah, why is it happening though? My point is that if it went out to everybody and came back, and then they redid it and went out again, that people can't say that at that point when it comes to the committee, people can't say didn't have a chance to see it. It's a done deal.
Tony,
That's my
let's take
point.
it offline. But again, people have a right to discuss. We just need the discussion has to be streamlined. But yes, you're right.
Okay.
We can address this further
Okay.
offline.
Let's move on. Dr. Barber, you had your hand up. Dr. Barber?
I rescind my hand raise.
Thank you
It
so
was
much.
it was a head scratch.
Okay, so we would like to, any further discussion regarding this protocol? If not, is there any further discussion? Okay, hearing that there is not, is there anyone in medical standards who opposes approving this protocol and moving it for roll call to REMAC? Okay, hearing none, Marie, I think we can do a roll call vote for REMAC to approve this protocol.
Okay, before we get started, I just want to ask, who is Brandon Trapp?
Oh, he's our fellow.
Okay. Just wanted to
He's a
make
good
sure
guy.
he
We
wasn't
can
some
keep him.
spy in the meeting. Okay.
No, I'm just one of the fellows listening in.
Okay, I was wondering if you were a dangerous person, so let me just get my stuff up.
No.
Okay, so this is approval of the abdominal pain protocol with, oh God, with removal of the second dose of Zofran.
Absolutely.
Okay, so that's correct. I just want to make sure. Okay. Okay, Robert Winchell, in favor, oppose, or abstain?
In favor.
Okay. And Joseph Schenker, we'll leave you for the end. Nick Alexandru?
Yes, approve.
Kevin Munjal?
Yes, approve.
Great. I see your children are under control now, huh?
I am in the backyard.
Cindy Vasilios.
Bothering me.
Okay, that's funny. Dario Gonzalez.
Approve.
Glennis Seda.
Yes.
Bradley Kaufman.
Yes.
Doug Isaacs.
Yes.
Nathan Reisman. Nathan?
Are we voting on the protocol as a whole or on removal of the second dose?
It's the whole protocol with the removal of the second dose of Zofran.
Okay, yes. I vote yes.
Thank you. Jeff Rabrich?
Yes.
Thank you. Reed Caldwell?
Yes.
Lewis Marshall?
Yes.
And I did not forget you this time, Dr. Marshall.
Thank you so much.
Michael Redlener?
Yes.
Okay. Laura Ivacoli?
Yes.
Thank you. Peter Wire?
Yes.
Paul Barbara?
Yes.
David Benelli?
Yes.
Mark Cantor?
Yes.
Joseph Bove? Matthew Harris?
Approve.
Robert Krupe?
Yes, proof.
Was that Dr. Bove? Oh, no, it was Dr. Krupe, sorry.
Yeah.
Jessica Van Voorhees? Arthur Cooper?
Approve.
Thanks. 2, 3, 1, 2, 3, 4.
Don't forget Dr. Schenker.
13, 14, 15, 16, 17.
It's not a tie, Dave. It doesn't matter.
So it's 21 in favor, so we don't need Dr. Schenker unless you want to vote. So it's 21 in favor, 0 abstentions, and 0 opposed. It carries. Okay.
Thank you very much, Dr. Lai. You'll make that change in the final protocol to remove the repeat dose. Let's move on to the next protocol, please.
Okay, great. So next protocol I have is the hyperglycemia protocol. This was originally presented as a 2 separate protocols for adult and a separate protocol for adults and a separate one for pediatric. That was then proposed through the protocol committee to actually combine these into one singular protocol. Where there are changes for that is, as you will see down in the section under the paramedics, where it's the crystalline fluid administration, where it is currently written as a weight-based dose that we currently use 20 mLs per kilogram with the maximum of 1 liter. The maximum of 1 liter is the same as it was previously in the pediatric protocol as well as for the adults. So then we thought that this would be something that we could do to make this to streamline this into one protocol. David, I do not believe am I missing anything, or I think that was pretty much the big change that was made in this protocol.
Yeah, there was the collaborative protocol talked about 400 milligram, 400 a sugar level of 400 instead of 300. We processed out to 300 with symptoms and 500 without symptoms. We felt that that's appropriate.
Right,
Other
and that's something that what we are currently using. Yes, that's correct.
Exactly. Okay, any discussion regarding this protocol from medical standards point of view? Very good. Hearing none, then we are going to vote for medical standards to forward this for a roll call in REMAC. Is there anyone on medical standards who opposes this protocol or wants to make any changes before we do a roll call on REMAC? Excellent, thank you. Hearing none, Marie, please do a roll call to approve this protocol for REMAC.
Okay. Okay, so we're voting to approve the hyperglycemia protocol as it is. In favor, oppose, or abstain? Robert Winchell.
In favor, sorry. In favor.
Thank you. Nick Alexandru.
Yes, in favor, Marie.
Kevin Munjal.
Yes, approve.
Cindy Basilios.
Approve.
Dario Gonzalez.
In favor.
Glennis Seda.
Yes.
Bradley Kaufman.
Yes.
Doug Isaacs,
In favor.
Nathan Reisman,
Yes, approved.
Jeff Rabrich,
Yes, approve.
Reed Caldwell,
Yes.
Lewis Marshall,
Yes.
Michael Redlener,
Approve.
Laura Ivacoli,
Approve.
Peter Wire.
Yes.
Paul Barbara,
Approve.
David Benelli,
Approve.
whoops. Mark Cantor,
Approve.
Joseph Bove, Matthew Harris,
Approve.
Robert Krupe,
Approve.
and Arthur Cooper.
Approve.
Okay, it's unanimous. 2, 3, 4, 6.
Thank you very much. Dr. Lai, let's move on to the next protocol, please.
Great, will do. So we will move on to seizures next. So you can see the new screen I have. I will make this bigger for everyone so it's easier to see. Okay, so for seizures, so again, so David, please interject since as needed, since you were the one that was that helped to prepare this protocol. So again, with the seizure protocol, this is something that was initially done as a separate adult and pediatric protocol, and has now been combined into one protocol to encompass for both adult and pediatric patients. The CFR and EMT sections, the only addition that was made for the, well, actually, I don't believe that there was any changes for the CFR or the EMT section. It is now for when we go down to the paramedic section. David, did you want to say something?
Nope. Go ahead.
No, okay. For the paramedic section, so that now that we have for the benzodiazepine choices that we have still for patients who are actively seizing, that they have options of either midazolam, lorazepam, or diazepam that will be used. The medical control option again is that if the patient continues to actively seize, they can administer an additional dose of any of the standing order medications as written above. One thing that I do want to note that we did to kind of make this into both an adult and pediatric protocol is that we have so that the EMTs are going to be treating the blood glucose levels and treat appropriately as needed. That is to make reference to the altered mental status protocol that we will also be reviewing later on today. And then for the key points and considerations, again, this is similar language, but it's just that just to emphasize that the intravascular access is the preferred route for benzodiazepine administration if it has already been established. If not, then intranasal is the preferred route over intramuscular. David, do you want to add anything for this protocol?
No. There are a couple of changes. The pediatric seizure protocol called for a hypoglycemic patient that is seizing to immediately administer IM, intramuscular glucagon. We have now allowed, and that's reflected in the AMS protocol, we have now allowed up to 2 IV attempts because we believe that's a faster and better way to address hypoglycemia than IM glucagon and to stop the seizing. And we did add one thing in the key points that talks about preeclampsia and direct to the appropriate obstetric emergencies that you need to consider treating preeclampsia in patients who are about to deliver or have just delivered. There's a comment over there that talks about that. Yeah, consider eclampsia as a cause for seizures for patients in advanced stages of pregnancy or have delivered within a month. and that is from the collaborative protocol. Any discussion regarding the seizure protocol? Excellent. If there are no comments,
I have a comment just on that.
Go ahead.
Sorry, it might be nitpicky, but advanced stages of pregnancy sounds strange to me. Should we just say like third trimester or second to third trimester? Advanced stages sounds like it's a cancer.
I'm okay with writing third trimester. You want to make a motion, Brad?
Yes. I make a motion to change to the patients in the second or third trimester.
Okay.
I'll second that.
Excellent. Can I add on to that motion, instead of writing 30 days, writing 1 month? Makes life a little easier.
Sure.
Okay. Is there
Do you need a
any
motion
further
for the 1 month?
Can't we take
maybe?
that as
Okay.
a clerical change?
I take it as a
Yes. I agree. We'll just do them together. Any discussion regarding Brad's motion?
I think Jeff is saying maybe my whole motion's just a clerical change.
Yes,
Yeah.
that's what I'm saying. It doesn't substantively
yeah.
change anything. So
Yeah,
do
it
we
doesn't.
really have to vote on it?
Yeah, I don't think.
I agree. Okay, let me just do it simple then. I agree with that. Thank you, Jeff. Is there anyone who opposes Brad's motion?
Brad's clerical changes.
It's not a
Clerical
motion.
cha-
The clerical
Not a motion. Thank you. Thank you,
not
Aditya.
nothing to do about it.
Wordsmithing. Brad's wordsmithing.
Yes, thank you.
Okay, if there's no objection, is there any further discussion about this protocol? Okay, so Pam, you're gonna just change the wording to write third trimester and 1 month instead of 30 days. Any further discussion about that? Or about the protocol? Very good. Let's move on to medical standards. Voting to move this as second in motion to REMAC for approval. Is there anyone who opposes this? Please speak now. Okay, hearing none, Marie, please do a roll call for this protocol for approval in REMAC.
Okay. Okay, we are voting on the seizure protocol with the word smithing by Dr. Lyde to change it to third trimester and remove 30 days. Okay. Robert Winchell,
Approve.
Nick Alexandru,
Approve.
Kevin Munjal,
Approve.
Cindy Basilios,
Approve.
Dario Gonzalez,
Approve.
Glennis Seda,
Yes.
Brad Kaufman,
Approve.
Doug Isaacs,
Approve.
Nathan Reisman,
Approve.
Jeff Rabrich,
Approve.
Reed Caldwell,
Approve.
Louis Marshall,
Approve.
Michael Redlener,
Approve.
Laura, I keep pronouncing your name incorrectly. Iavicoli.
Approve.
You'd think I could pronounce it, I'm Italian, but I'm messing it up. Peter Wire,
Approve.
Paul Barbara,
Approve.
David Benelli,
Approve.
Mark Cantor,
Approve.
Joseph Bove,
Yes.
Matthew Harris,
Hooray.
Robert Krupe,
Approve.
Jessica Van
It
Voorhees.
only counts as one.
I know. Arthur Cooper. Dr. Cooper?
There we are. My thing wasn't unmuting. Yes, I approve.
Thank you. That's unanimously in favor. 2, 3, 4, 5.
Can I enter my twin into the REMAC at a young age or no?
What was that?
Never mind. Never mind.
Okay.
Okay, thank you, Dr. Lai. Let's move on to the next protocol, please.
Perfect. So the next protocol is, we'll start off with altered mental status. That again is a, this is, I believe that this is, no, actually, so this was always the same as in terms of like a adult and a pediatric. But in terms of changes that were made here, so the biggest change that we did do after discussion in the protocol committee meeting was that to remove a lot of the language and a lot of the direction that was given for opioid overdoses. We simply made this now in the CFR section to be changed to that if an opioid overdose is suspected, to treat accordingly as needed, and that will be in reference to our overdose protocol that we have yet to be discussed, and if you would like to, is going to be discussed at our protocol meeting this coming Friday at 10 a.m. So all of the naloxone language is then removed just to streamline the protocol and to have all the naloxone language basically live in our overdose protocol and not in this altered mental status protocol. So otherwise, the BGL, checking the BGL and having the limit for treatment to be 60 milligrams per deciliter has remained the same. There was just some wordsmithing changes that were added on here just to make this more clear in terms of when an EMT is able to administer a glucose solution and other sugar-containing beverage. Next, under the paramedic section, this has pretty much just remained the same just in terms of our dosing. Dextrose is going to be up to 25 grams, IV bolus. And again, that has still remained the same for the pediatric patients with the differences in the formulations for dextrose depending on the age. Glucagon here is going to be given as what the route of choice is if an intravascular access is unavailable. And again, we have that as the first key point of consideration, that especially for the pediatric patients, that what David had mentioned before, that no more than 2 attempts at attaining intravascular access shall be made before administering glucagon, and that intranasal glucagon would be the preferred administration route as available. But otherwise, Nathan, I know that you had kind of helped to prepare this protocol. Is there anything that I'm missing for the altered mental status protocol?
No, most of the changes was just cleaning up the language and making it and taking out the stuff that was there from before we had glucometers for everyone. There weren't any real major changes.
Excellent, thank you. Any discussion regarding this protocol?
I just want to ask, is Dr. Berkowitz in? Was he able to get in?
Let me look. I don't see him as requesting to get in.
He was in before.
Yeah, I don't see him in the waiting room. Oh, here he is. Okay. I just let him in. Sorry. You can go ahead. We're ready.
Okay, very good. So any discussion regarding this protocol? Okay, hearing no comments about this protocol, no discussion. We're going to move this to medical standards. We'll move this for roll call to REMAC. Anyone who opposes moving this protocol on medical standards, anyone on medical standards who opposes moving this protocol for roll call approval at REMAC, please let me know now. Okay, hearing none, Marie, we can go to do a REMAC roll call to approve this protocol.
Okay. Okay, so we are voting on the altered mental status protocol. Robert Winchell.
Approve.
Nick Alexandru.
Yes, approved.
Kevin Munjal.
Approve.
Cindy Basilios,
Approve.
Dario Gonzalez,
Approve.
Glenn Aceda,
Yes.
Bradley Kaufman,
Yes.
Doug Isaacs,
Yes.
Nathan Reisman,
Yes, approved.
Jeff Rabrich,
Yes.
Reed Caldwell,
Yes.
Lewis Marshall,
Yes.
Michael Redlener,
Yes.
Laura Iavicoli. It's so dumb.
Approve.
I don't know what's wrong with me. Peter Wire.
Yes.
Thank you. Paul Barbara,
Yes.
David Benelli,
Yes.
Mark Cantor,
Yes.
Joseph Bove,
Yes.
Matthew Harris,
Yes.
Robert Krupe,
Yes.
and Arthur Cooper.
Yes.
Once again, it's unanimous.
Very good. Thank you very much, Dr. Lai. Let's move on to the next protocol,
Hey,
please.
I'm sorry, point of something, order. Kanika, is anybody else interested in a 5-minute bathroom break? Seems like we've been going a long time.
Yeah, we can take a 5-minute break. It's
I'll leave
now
it to the chair,
8.
but I don't know how much more we have.
That's fine. We do have.
Are we done with protocol?
No, we're not done with protocol
No,
yet.
I'm sorry. We
then we
have
have
one
the
more protocol left to go.
So why don't we do this? Why don't we, Brad, can we finish protocol and then you can go pee?
Yes, of course.
All right, so
Fair
we'll do
enough.
protocol.
I'd be glad
Let's
to
get
hear that, Brad.
break before we do
Oh
interview.
my God.
Okay,
Take an
so
extra Flomax, Brad.
We'll take a. Okay, so we will finish, guys. We will finish protocol.
it's
Then
so
we still
mean.
have inter-facility protocol, and we still have a presentation. So, Dr. Lai, the last protocol for tonight.
Yes. So the last protocol is anaphylaxis / severe allergic reaction. So again, this is a protocol that was originally put forth as a separate adult and a separate pediatric protocol that was moved by the protocol committee to combine to make this into one singular protocol. Just to start off, this protocol was thought that it would better encompass a lot of the patient conditions that are sort of like in this protocol by adding that severe allergic reaction first off to the title. And that is one of the changes that we have on here. Otherwise, the other thing that I do want to make note of is that while it does not say explicitly in the CFR and all provider section in terms of considering administration of epinephrine for those patients who have a history of anaphylaxis and with a exposure to an allergen, that is now actually in our key points in consideration section, so that it will be able to apply to all providers. But that it has still been on there, but has been just to be put into the key points in consideration section. Otherwise, in terms of the actual administration of epinephrine, that has not changed at all in terms of either the age limits or the weight limits for the, and this is what is currently reflected in our unified protocols in terms of for the using when to use the pediatric epinephrine auto injectors versus the adult. That has remained the same. A lot of this has just been a lot of sort of like language clarification. Excuse me, that is in terms of this protocol, at least for the CFR and the EMT sections. When we go down to the paramedic sections, it was thought that we would like to keep these patients who are still exhibiting signs of shock, that these patients would best suited to if they're still having those symptoms, if they're reaching that paramedic level after having received epinephrine by either CFRs and or EMTs, that would be best served that those patients still be kept into this protocol and to then access the medical control options if those patients are to remain shock, rather than for them to be referred to the shock protocol. The other change that has been on here through some research in terms of the dosing for methylprednisolone, that has been changed to 1 milligram per kilogram with a maximum dose of 60 milligrams, as opposed to the 2 milligrams per kilogram with the max of 125. I think that was there before. Dexamethasone dosing has remained the same. This was just based on current evidence, and current best practices. The diphenhydramine, that has still remained the same with the dosing on there. And then that is also the same for the ipratropium as well, with the dosing for the adults as well as for the pediatrics as below. Medical control options, again, have not changed. Everything was just been kind of just looks a little bit different, just because just to try and make things a little bit more clear. But otherwise, all the options are clearly marked, both either for the EMT level or for the paramedic level. I think, I'm sorry, and then also one other change of note was that dexamethasone, there was a note on there that the IV formulation for dexamethasone may be administered orally, and then that was then reflected up above for the dexamethasone. So otherwise, Nathan, do you want to add anything else?
No, I think the main two changes were the change in the methylprednisolone dosing. That's according to the current guidelines. The 125 dosing was from old guidelines that were changed in 2007, actually, which I didn't know until I was researching this protocol. And our current dosing is according to the current guidelines. The other change is the doses of epinephrine. We made it pretty clear that each level of certification can administer one additional dose, even if even if someone else had given before. And I think that's one thing that's a little confusing with these current combined protocols, is when different levels of certifications can give the same medication. Sometimes confusing when a paramedic gets on scene, can they give one dose or 3 dosing? So at the protocol committee, we decided to make it explicit. And now it's black and white how much everyone can give.
Thank you.
Nathan.
Thank you very much. This is a very extensive protocol, and a lot of hard work has been put into bringing this, making this streamlined and up to date with dosing. Any discussion regarding this protocol? Okay, having no comments regarding this protocol, anyone in medical standards opposes? Anyone in medical, is there anyone in medical standards who opposes moving this protocol forward to REMAC for approval? Please speak now. Excellent, thank you. Marie, this is unanimously being moved to REMAC for a roll call approval.
Okay. I guess it would be good if I unmuted myself. Okay. Okay, you know the drill. We are voting for the anaphylactic severe allergic reaction protocol. Dr. Winchell?
Approve.
Okay. Nick Alexandru?
Yes, approved.
Kevin Munjal?
Approve.
Cindy Basilios?
Approve.
We're almost there, guys. Last protocol. Dario Gonzalez?
Approve.
Glennis Seda? Glennis Seda?
Sorry, yes.
Brad Kaufman,
Approve.
Doug Isaacs,
Approve.
Nathan Reisman,
Approve.
Jeff Rabrich,
Approve.
Reed Caldwell,
Approve.
Lewis Marshall,
Approve.
Michael Redlener,
Approved.
Laura Iviacoli,
Approve.
Peter Wire,
Yes.
Paul Barbara,
Yes.
David Benelli,
In agreement.
Mark Cantor,
Approve.
Joseph Bove,
Yes.
Matthew Harris,
Approved.
Matthew, he's having fun. Robert Krupe,
Approve.
Arthur Cooper.
Approve.
Okay, that's unanimous. Thank you very much.
Thank you, Dr. Lai. Do you have anything further from the protocol committee?
Yeah, I just wanted to address the previous comments before, since I am in this this wonderful position of being the protocol committee chair, is that I would like to think that I do try to put things out there in terms of having these protocols. I have everything, have ample chance for everyone to review. And with the time settings, before the protocol committee meeting, that we are actually meeting now twice a month, as opposed to what was previously done before, just to kind of go through the protocols and be able to do a thorough review. I think most of the comments are people that are actually on my emails for the protocol committee. If you are not on those emails, I apologize, and then please let me know so that I can add you to the protocol committee list so that you will be receiving these protocols at the time of the protocol committee meetings. I am actually, however, open to any other sort of ideas to try and streamline things. As I have recently sent out an email to help to even try to streamline the conversations and discussions at the protocol committee. Everything is still always a work in progress. It is something that we're going to want to continue to work on, as we all agree that this is an issue both for the functionality of the protocol committee as well as for REMAC. Thank you.
Thank you very much, Dr. Lai. We encourage everyone to attend the protocol committee. It's an open meeting, and we can all join and talk. And there's extensive discussions during that meeting to try to address all concerns. So by the time it reaches medical standards and REMAC, the protocol has been rehashed and discussed again a number of times, and delved into, and all the minute details have been delved into in order to streamline this as much as possible. Okay, thank you, Dr. Lai. The next meeting of protocol committee is this Friday at 10 a.m. And we can share the Zoom link with everyone. At Dr. Kaufman's suggestion, it is now 7 p.m. We will take a 5-minute break until 7:05. And we'll resume with the okay, we'll still allow you to the 5 minutes, and at 7:05 we will resume with the interfacility transport report. Thank you. So 5 minutes, everyone.
Joe, if you're still online, Ranieri, should we stop the recording for 5 minutes?
You're not able to pause a live stream.
Okay, fine. We'll just leave it alone then. Thank you.
No point. You'll just have 5 minutes of silence.
Should play some music or have people sing. Well, maybe not.
Let's just have Dr. Harris's kids talk. Tell them they're live.
Here, let's say hi, sweetheart.
Hi.
Hi.
There you go.
You know what we're talking about?
Okay, so
we're talking about how people on ambulances help people. What do you think we should do? Should they help people with more toys or less toys? Less toys. Girl after my own heart. Should we be intubating in the field? Yes or no? No. Oh yes. Okay. We'll talk about it. Say hi, buddy.
Hi.
Hello.
Hello.
All right.
That was a good break. Oh, what's his name? Her name? Just dog?
Doggy.
Okay.
We'll talk about it in another meeting. Okay.
Okay.
This is why COVID has to end sooner.
Marie, I believe we can stop sharing the screen, Pam's screen.
I think that was, okay, let me just see. I don't know how to do this. To stop sharing her screen.
She has the shot, yeah.
Oh, okay, thank you.
Okay, 2 more minutes and we begin.
Joe Ranieri, just you said you can't pause the stream. I want you to also know you're not allowed to cross the streams, just for anyone who is wondering about that.
You're
Bad.
dating
Would that be
yourself,
bad?
Paul.
Well done.
It would be.
Imagine every molecule in your body simultaneously exploding at the speed of light. Okay, that'd be bad. Important safety note, everybody.
Fireman joke.
The desert.
Okay. Okay. Well, now that we addressed the safety issues, it's now 7:06. Let's resume the meeting. Dr. Berkowitz, the Interfacility Protocol Committee has met, and we're eager to hear your report.
Sure.
Wait a minute.
So
What? What's up, Marie?
Sorry, did I miss your meeting?
no, we
no,
met,
you
we
were
met
there.
a month ago.
Okay.
There's another one in 2 days.
Oh, okay, okay.
You haven't yet missed that one, but we'll give it a shot.
Okay, I'll try not to miss that one.
You might want to. So we met as a group and started to lay out the scope of work for this project to kind of put together some guidelines regarding IFT in the region. So I'll just give a summary. I think that Marie has shared the notes, but we have notes that we can share with the group. In the interest of people's sanity and time, I won't go through all the notes, but I'll give a kind of an overview and then open to get feedback from folks. So we talked a lot about the need for minimum standards regarding facility transport. And so we kind of had several different layers of minimum standards that we thought were relevant. So one was standards in the transport team level of care deployment, meaning what constitutes critical care, what constitutes specialty care, when maybe something might be a 2-paramedic job or not, and potentially other configurations of deployments with respiratory and perfusionist, et cetera, et cetera. So that was one area of minimum standard that we discussed. Another was minimum standards in the scope of practice and education. So defining what constitutes appropriate education for the different levels I mentioned above, as well as talking about specific equipment. Standards in terms of skill maintenance and competencies, and dedicated education regarding interfacility transport. That's outside of kind of standard CME. We talked about minimum standards for medical direction, and differentiated between transport orders, medical control en route and transport, and then adjudication of issues that arise regarding transfers. We talked about the concept of standards regarding availability and training of medical direction. We talked also about standards of prioritization, and talked about some of the various nomenclatures being used, ranging from emergent, time-sensitive, life-threatening, urgent, routine, scheduled, and rescue. And we talked about reducing unnecessary lights and sirens as part of that process. We talked about standards of communication, did a little discussion on peds versus adult, and also had some very light discussion on behavioral transports, because I think that's probably a whole other headache. We also started to talk about what the ability that we believe that we could have to regulate interfacility transport in the region. I think we agreed that everything we're discussing, even at the level of kind of transport pumps and everything else, kind of falls in the level of SCT, and then for the more complicated patients, critical care. But I think we may want to talk about that further. And then there's some open questions that I think that are for the next meeting in 2 days to talk about what we can regulate versus what we can just recommend or endorse. And then we went through a discussion of some of the barriers that we think we're going to have. And some of those barriers is still, I think one of them is that we need to kind of finalize what we know about what we can regulate and what our role is. We have to make sure that the financial impact does not negatively impact the system, both in terms of the guidelines and standards and also for the training equipment component. And then we talked about the local relationships and reaching out to the Nassau and Westchester REMACs, which we already have done, and then talking about some interoperability. So that's kind of a summary of what was discussed. I'm open to any suggestions, especially on the component of, because I think we did a really good job of assessing the needs, but I think that there's still more discovery that we need to have on what we can do to regulate or what our role can be. and I'm open to hear from folks here. And we can, and we probably can also have discussions with folks at the state level and in other regions as well. So that's the report. I'm open to thoughts and suggestions and questions.
Thank you, Dr. Berkowitz. Any discussion, comments, questions? Okay, so thank you, Dr. Berkowitz, for the summary of the meeting. It was a very, very interesting meeting. There's a lot of topics to cover and discuss, and I encourage people to participate in this committee. The next meeting, I believe, is next Thursday. This coming Thursday at 1 p.m. If I'm
Yes.
correct. Yes, correct. Okay, thank you very much. Moving on with our agenda, any unfinished business? Okay, I don't believe there is unfinished business. Any new business that anyone wishes to bring up to medical standards? Very good. Joe, we'll leave the, Dr. Schenker, we'll leave the, we were scheduled to have a presentation today to talk about ECMO.
There's a couple of things that we need to cover. There's a couple of things that we need to cover during REMAC. I think that we're going to discuss the concept behind that presentation, but I will ask that the presenter be moved to next meeting for the simple reason that I think that we're getting to the end of the road here. What I would say is that we do have a few things that we do need to discuss shy of that presentation. So as soon as you're done, Dave, I will move on to that stuff.
Yeah. Okay. Unless I hear, is there a motion to adjourn the medical standards section of this?
Motion to adjourn.
Motion to adjourn.
Motion to adjourn.
Excellent. Is there anyone who opposes? Otherwise, that ends the medical standards section of this meeting. Okay. Thank you, Dr. Schenker.
All right, so I will keep this very brief and try to get us done pretty quickly. First is we had a nomination for the psychiatric physician, Dr. Bodick, who was on our call last week. I don't know if she's on our call now, but the membership committee, actually really the executive committee met and felt that she was the most appropriate person to put forward for for the position. So Dr. Bodick is nominated or is up for nomination. We do need to vote on nominating her, which would then go to REMSCO for approval. That's one item. And then we have two more items to discuss and then we'll hopefully be done. So Marie, if we could vote on that, I guess it has to be, we can just, is anybody opposed? Let me put it that way. Is there any
Can we just get a little
opposition to
background?
Dr. Bodick?
Joe.
Yeah,
sorry,
her CV was sent out. We discussed it
Sorry, I
previously.
missed it.
Yeah, her CV was sent out to everybody. Actually, you know what? I'm just going to move rooms for a second, guys. Just bear with me. Yeah. Is everybody there?
Yeah, can you bring it up?
Yeah, no.
Yeah,
I
she
can
does
bring up
have
her
acute
CV.
care, psychiatric experience, and CPEP experience.
Yeah, and we did send out her, that'll be the second time we've sent out her resume.
Yes. So does that, I mean, if anybody would like to see her resume, I could put it up, but you all did have it in your emails. And again, if there's somebody who has, would somebody like me to put it up? I'll ask that to the group. I should try.
I'm good.
All right. So seeing no opposition, Marie, let's take this as a motion from REMAC to submit this to REMSCO for nomination as the psychiatric physician.
Okay, do we need to do a roll call vote or can we just?
We do not need to do, it doesn't affect any protocols.
Okay.
Okay. Next item. The REMAC bylaws were changed at the last meeting. I'm kind of going out of order here a little bit, and I apologize. But I just want to get this done because I think we're starting to lose brain cells. I would like to just read the changes that were put in and show them so that everybody knows what the changes are. This is the second reading of the bylaws, and if there's no changes, we will go to the next meeting and hopefully approve it at that time. I'm going to try to share my screen here. Yeah, there we go.
Okay, this was also sent to everyone.
Okay, so this is the bylaws. The change that was made is right over here from the Medical Standards Committee. The chairperson and vice chairperson were removed, leaving a municipal FDNY EMS physician and a non-municipal physician. Those are under the appointment process, and I'm sorry I'm going through this.
Joe, if you go back up, it should probably say physician over there. I don't know why it says just non-municipal.
Well, okay, yes. So Marie, if we can make it physician, because
okay,
yeah, for both of them. Yes. This is just
in the physician column. It's in the physician
column. I take that back. I take
physicians over here.
Yeah.
I take that back. Sorry.
And then under the appointment process, for the purposes of nominating representatives from the Medical Standards Committee, the chair of Medical Standards will appoint a municipal FDNY EMS physician and a non-municipal physician representative. So this allows for the chair of Medical Standards to be a non-physician, yet appoint 2 REMAC voting members to REMAC. Are there any questions? That's the only change that was made from previous. Is there any questions about this change? If there aren't any, we will assume that this reading is done and move on with the meeting.
Great.
Any questions? All right, hearing none and seeing none, I'm going to stop sharing this and move to the next part of this meeting. Okay. Okay, so the executive committee did meet to, I'm just going to quickly go through our subcommittee reports. Medical Standards Subcommittee, obviously we just had that as part of our meeting. The executive committee did meet to nominate Dr. Bodick. The QA report, Dr. Redlener, if you don't mind.
Thanks, Joe. The QA and QI committee did not meet between last meeting and this. We are rescheduled for a time to be announced in the near future for the February meeting.
Thank you. Training and education, Mr. Lax, are you there?
Morty's not here tonight. They are going to meet sometime during this month.
Excellent. Okay. Did RTEC meet since our last meeting?
Not that I know of, unless anyone else has. I haven't gotten any announcements.
I don't think so, Joe.
I don't believe so.
Okay, great. Lou, the CMAC update. Do you want to give that?
Yeah, sure. CMAC met on January and approved 7 motions, including one from a region that was having problems getting a particular dose of acetaminophen. So they approved giving 640 milligrams liquid instead of 650 milligrams. The next one was revisions to the medical formulary to add Tylenol dose formulation, as well as regions can make changes to medication formulary dose as long as the Bureau is informed. They approved the collaborative trauma hemorrhagic shock protocol changes, which added tranexamic acid infusion and blood transfusion of 1 unit of type O negative. Both options would be available if approved by the medical director and available by trained providers. I was surprised that that got through.
Lou, do you still need to be an ATS in order to give blood, or this
did not say that.
ATS?
This did not say that. This was, yeah, that's exactly right. So this was in trauma hemorrhagic shock protocol. So presumably you could give a unit of type O negative if you had it on the bus. The nausea protocol was approved to include self-administration of isopropyl alcohol inhalation. So apparently back since 1998, there have been research articles on the use of inhalation of isopropyl alcohol in relieving nausea. And there was a recent article in the American Journal of Emergency Medicine, I believe, that actually looked at this at triage and showed an improvement in reduction in nausea symptoms and in length of stay in the emergency department. So I tried it. It didn't work for me.
That's I'm gonna add that to my practice.
I know, right?
People swear by this. It works.
It works.
Yeah, I know.
Yeah.
They added changes to the excited delirium protocol, which added the use of waveform capnography for all patients who require sedation when safe and feasible. Changes to the epistaxis protocol, which just allowed for oxymetazoline to be sprayed up somebody's nose and then pinching it. Airway management and oxygen administration protocol was changed so that the O2 sat should be at 92% or above and require a viral filter for all patients with a supraglottic airway or endotracheal tube. And then the New York City vaccination protocol was approved, and just with some wording changes to allow a little flexibility in terms of the needle size and length, and added based upon manufacturer's recommendations. So the next meeting of CMAC and REMSCO will be sometime in May. That date has not been set. But that is my report.
Thank you. Any questions for Dr. Marshall?
Yeah. Hi, it's Brad. I have a question.
Yeah.
So I know we're working towards getting blood in the field, but just because currently that's not in our protocol, just to clarify, right? It could be like an EMS agency in our region couldn't currently carry blood until we approve them. Is that correct?
Correct.
Okay.
I think that, yeah, I think even based upon the information from the state from the last time, I think you still have to be, I would imagine an agency would have to be approved.
Yeah.
To
Yeah,
carry.
you'd have to be an ATS, I think, because how else would you carry it?
Yeah, because otherwise you're not going to carry it. So if you're approved and you're carrying it, then you could administer it.
Yeah, that's correct, because we have a rescue protocol approved for blood transfusion, but we're still waiting for our state certification as a blood transfusion service.
Right. Okay.
Excellent. Any other questions? Okay, so seeing no other questions, regional council update. You did, Joe?
Okay, very quickly, the ambulance committee met on the REMSCO met on January 26, 2021. They will provide a technical assistance to citywide mobile response to correct deficiencies identified by the New York State DOH. Ridgewood VAC application was deemed complete. Forest Hills VAC application for territory expansion deemed incomplete. The security ID tag, you remember those ID cards that we all had, will be reactivated to finalize the format. Territory clarification for Glen Oaks VAC was approved and submitted to New York State DOH. For those who don't know, in Queens, they are fighting over various territories, and the DOH will have to work that out. I think the most important thing we accomplished, and I really want to ask REMAC to do it as well. REMSCO officially thanked the staff, the REMSCO staff, for the work during the pandemic, which included operationalizing the pods for EMS providers to be vaccinated. Okay, the work that they did was phenomenal for all the EMS volunteers who are not part of a system where they were able to get vaccinated. Personally, I will attest that it went smoother than I've ever seen any operation work, period. It went well. Marie gets undue credit for doing this, as well as her staff, and REMSCO made a threat, and I would like to propose that REMAC similarly thank the staff on the record for all the work that they've done and continue to do with the pods for vaccination.
I agree. Having been at the pods and overseeing a lot of what was going on from the vaccination perspective, Marie, Joe, Scott, you guys really did more than your share to get this done in a time effective way. So I do thank you on behalf of the entire group. And it did run incredibly smoothly at both locations. So thank you very much.
Okay, and finally, the mental health team has begun a training initiative. And the next meeting of REMSCO, Marie, is when? I don't have my calendar here.
We're meeting on the 23rd.
On the 23rd. And that is the end of my report. Thank you.
Okay. All right. So the final thing I wanted to discuss, and we've been on this call now for 2.5 hours, so I don't think a presentation right now will help. But what the presentation was about, and what we're talking about today, is starting to look into the feasibility and use of ECMO centers in New York City in the management of resuscitation medicine. And it's definitely something that we need to, there is a lot of literature to support resuscitation centers and focused care for resuscitation in different areas. And it's something that, similar to what we've done in the past with stroke centers and so on, is going to take a little bit of education to figure out what resources we have available, how we can deploy that to the entire city, and so on. So I would like to propose that we have a tag that meets sometime between now and the next REMAC meeting. This tag will begin the discussion. At the next meeting, we will have a presentation from one of the critical care physicians in the region who is doing this, and take it from there. So any discussion on this? I know that Dr. Benelli had approached me about this, and I'd like for him and I will co-chair a tag for this. Anyone who is interested, please feel free to join the discussion now, as well as submit to Marie, so we can put together this group and meet between now and the next meeting, which is on March 9th, so a month from today. Any discussion? Anybody want to add anything to this, to the beginning of this idea and this concept going forward?
Joe,
all right, go ahead.
Yeah, all I want to say is that I think I personally would like to hear the presentation before we, go a lot further with this. I recognize you want to get a group together, within the next month, but I'd like to hear a little bit more of the evidentiary basis for this, because it's a big deal we'd be undertaking, and that's really all I have to say. Thank you.
Yeah, no, I agree. And I just, again, I don't think that in one meeting we will, possibly what I'd like to see between now and the next meeting is just trying to outline some of the pieces of the puzzle that will need to happen going forward, and a kind of a proposed timeline for how this will be, and then to have the evidence presented at the next meeting, and then take that forward from there. I just think that it's been a long night, and I don't know that, our brain is pretty spent. If everybody wants to have it, I think that Paul could probably arrange that. But I think that I'd rather us start putting pieces together and then have a presentation when we're all ready to hear it. Paul?
I wasn't suggesting tonight, by the way.
Oh, I hear you. Go ahead, Paul.
I'm happy to share the literature with anyone who wants. I would just encourage we read it before the next meeting.
Agreed. Anybody else? Okay, so again, like I said, if you're interested in participating in a tag to begin the evaluation of ECMO centers, please submit via email to Marie, and we will hopefully get the literature out and have a meeting before the next REMAC meeting to kind of start the ball rolling and get the process underway. And that's the only new business I have. Is there anybody else with new business? All right, hearing none, I will entertain a motion to adjourn.
Motion to adjourn.
Second?
Second.
Excellent. Have a great night, everybody.
Thank you. Good night. Thank you.
Have a good night all.
Marie, are you still there?